Hello, I'm Michael Deininger from the Medical College of Wisconsin and the Versity Blood Research Institute. I'll talk to you about the role of genomic analysis and panel mutation screening in chronic myeloid leukemia as part of the ICML of Knowledge Center. These are my disclosures. I will say that none of these will in any way influence what I'm going to tell you. I think I should start out with a few definitions. So first of all, if we talk about BCR-ABL1 mutation screening, this means targeted sequencing of the BCR-ABL gene, typically the kinase domain, or the entire BCR-ABL sequence. And that would detect mutations in BCR-ABL. If we talk about panel mutation screening, then typically this means the sequencing of multiple genes associated with cancer, or in the context of CML, typically associated with myeloid malignancies. Importantly, these panels differ in the selection of genes. Some are more comprehensive, some are less comprehensive. So it really depends on how extensive the panel is, what kind of how comprehensive the information is you can derive from that. Most of these myeloid mutation panels will have some genes that are also mutated in lymphoid malignancies, but many will not. So if you have lymphoid blast phase in a patient, it may be a good idea to talk to somebody to see whether they have a lymphoid panel available that you could use. Cytogenetics is not a molecular test in the true sense, but still gives us really important information and should never be omitted. And then lastly, fluorescence in situ hybridization of FISH will screen for selected numerical and structural chromosomal changes, but for most practical purposes is not really part of the diagnostic armamentarium in CML. If we treat patients with CML with tyrosine kinase inhibitor, then the disease burden shrinks, typically. Initially, there may be as many as 10 to the 12 leukemic cells in a given patient, but then as treatment starts, we achieve typically a complete hematologic and then subsequently a complete cytogenetic and then eventually a molecular response. There are some definitions around here. Everything that is below a 4 log reduction is referred to as a deep molecular response. A 3 log reduction is referred to as a major molecular response. And then a complete cytogenetic response would be equivalent to a 2 log reduction. Now, why is that important? It is important because at these low levels of residual disease, any type of mutation screening is usually not indicated and not successful to monitor CML. It may be indicated if somebody is in a very good response and has abnormal blood counts that would potentially point to a disease that is evolving that is not CML, such as a myelodysplastic syndrome or another myeloproliferative disorder. However, this is really not the focus of our talk today. The NCCN guidelines committee in the United States and the ELN in Europe have defined certain response time points or benchmarks that patients would be expected to meet if we want to consider their response as optimal, suboptimal, or failure. And without going into too much detail, it is important that the definition of TKI failure should be based on these guidelines. They are evidently made for chronic phase CML, not for patients who are diagnosed in blast phase or accelerated phase. Every patient who is in the yellow or red area here is a potential candidate for more extensive molecular testing. This is what I believe reflects current knowledge that supports clinical practice. So I have broken down the testing to cytogenetics, FISH, BCR-ABL mutation screening, and myeloid mutation screening. at diagnosis or on TKI therapy. At the time of diagnosis, cytogenetics will always be part of the typical workup. FISH is not indicated. BCR-ABL mutation screening is also not indicated as long as the patient is in chronic phase. There are some suggestions that we should consider BCR-ABL mutation screening in blast phase, but the issue is that it is a very low yield test, and typically it doesn't impact therapeutic decisions. So in my mind, not to be recommended. And lastly, myeloid mutation screening, certainly not in chronic phase CML, but perhaps in accelerated phase or blast phase. And I think this is the subject of ongoing studies. Now on TKI therapy, this changes. Now cytogenetics is still critical. FISH has not much of a role. Some people would perform panels for MDS or AML, but I don't think this is generally accepted. BCR mutation screening is critical, and certainly myeloid mutation screening if the patient has progressed to accelerated phase or blast phase. I think there's still some question about the value of that in as long as the patient is in chronic phase. Now, if you look at resistance, what we get from these various tests is essentially information on the basic or underlying resistance mechanism. If we consider BCR reactivation, then we will typically find a kinase domain mutation, such as the T59 mutation in a patient with resistance to imatinib. That is important information because it will, to some extent, drive the next line of treatment. In many cases, however, we will find no BCR mutation, and the current thinking is that in these cases, mutations other than BCR in genes other than BCR-ABL are contributing or are responsible for the resistant phenotype. Now let's first talk a little bit about BCR-ABL point mutations. There are many that confer resistance to imatinib, but only one, the T59 mutation, that confers resistance to all three second-generation TKIs currently approved, so to nilotinib, bosutinib, and dasatinib. And so detection of this mutation would trigger the selection of ponatinib as the salvage therapy because it's the only currently approved inhibitor that has activity against the T59 mutant. Now you can use this information to guide you in the selection of your second-line agent. I think the most glaring example is what I already mentioned, is T59, so you would not expect a response here to any of these first and second generation inhibitors, but you would expect a response to ponatinib. But there are other choices. So for instance, E255V would not be a good idea for nilotinib, but should be covered pretty well with dasatinib. So that gives you some hints of what to use next. Importantly, it really correlates well towards the negative, or better towards the negative side than towards the positive side. And that is to say, if a patient has a mutation that should be quote unquote sensitive to a given TKI, that doesn't guarantee a response because other mechanisms may contribute. Conversely, if you have a T59 mutation and you try to treat that patient with anything else but ponatinib, as far as approved inhibitors are concerned, you cannot expect a response. It's just to give you an example here. This is chronic phase CML response to dasatinib by individual baseline BCR-ABL mutation. And you see basically complete, that's all data, by the way, complete cytogenetic response or no response. And as you see, this really corresponds fairly well with the level of sensitivity as determined by cellular IC50 determination. So for instance, these mutations G250E or V or M244V will respond, will confer sensitivity, whereas T59, as already mentioned, will not be responsive. Now, in some cases, what you may see is the emergence of more than one BCR-ABL mutation. Now, it's important to distinguish here between polyclonal resistance or polyclonal mutations and what we refer to as compound mutations. Polyclonal means these mutations sit in different BCR-ABL clones. And so response will be determined by the sensitivity of each individual mutant to the TKI you choose. In the case of a compound mutation, that is different. For instance, here, this is a patient with an E255V T59 compound mutation. So 2 mutations in the same BCR-ABL allele, who was treated with ponatinib. And as you see, there's very fast, very rapid selection of this mutant clone on treatment. And then you can rationalize it by computational modeling. And you see that this mutation here or this double mutation, compound mutation, would lead to sterical clashes with ponatinib. So the only way of finding that out in a routine clinical setting is if the mutant allele frequencies of the 2 mutations that you pick up add up to significantly more than 100%. In other cases, you cannot be really sure, and in this case, you may have to talk to an experimental lab also to get more information. Why is it important? If these mutations involve T59, they confer resistance to all currently approved TKIs. Now, let's talk a little bit about chromosomal abnormalities. This is a diagnostic test that we had available for a long time, and although it's not molecular, it gives you important information. We distinguish between major route abnormalities, that is a second pH, +8, +19, isochrome 17, and minor route abnormalities, which is basically everything else. Now, bear in mind that these are all definitions that essentially reflect the frequency of these abnormalities, and as such are not necessarily telling you much about their biology. But suffice it to say that if you have, one of these abnormalities here at the time of diagnosis, and you're treated with imatinib, your outcome is very significantly worse. So it's important to continue to do cytogenetics at diagnosis, because you might find one of these abnormalities, and then that could influence or will influence your treatment decisions. Now, I think if we talk about panel mutation testing, I think what many of us will have in mind nowadays is the detection of somatic mutations, typically point mutations or indels, insertion deletion mutations in genes other than BCR-ABL. These genes will typically be associated with hematologic malignancies and mostly with myeloid malignancies. And as you see here, there is no really convincing pattern emerging. And rather than that, many different genes can carry mutations. These are 2 independent studies, and as you see here, what you pick up at the time of prostate transformation is, of course, BCR-ABL kinase mutations, but also mutations in a number of other genes, such as RUNX1, this is here, and also, let me see, here, or ASXL1, which is also relatively frequently here and relatively frequently here. Now, I think the differences here probably reflect the still relatively small number of patients. So what are we going to do with these data, and when should we consider sequencing in the first place? Now, one question is, assuming that at least some mutations are pre-existent at the time of diagnosis, does it not make sense to sequence all chronic phase patients? I think at the time, that doesn't make sense. We will pick up mutations in a subset of chronic phase patients, but it is not quite clear how they impact their prognosis. I think the prediction would be that altogether, the presence of additional mutations reflects more advanced disease. But I think the data at this point does not really support to use that as a decision maker, say for the specific choice of a tyrosine kinase inhibitor over another one, or for referral to transplant or other more drastic interventions. The most frequent mutation present at diagnosis of chronic phase is ASXL1. And so one suspicion is that at least some of these cases might reflect pre-existing clonal hematopoiesis, where ASXL1 is one of the most frequently mutated genes, and then the CML clone basically develops, or the BCR-ABL is acquired on the back of this clone, and then the ASXL1 mutation is carried forward into the CML population. And there is indeed some evidence for that, at least in some patients. These mutations at the time of blast phase transformation may either just persist at the same level, or they may increase if they are relatively low allele burden, or they may actually expand. So it's really unpredictable what exactly is going to happen. In contrast, if you have a RUNX1 mutation, that is almost always selected at the time of blastic transformation. And there's plenty of data to suggest that RUNX1 mutations actually actively contribute to the blastic phenotype, perhaps by interfering with proper differentiation. Similar for TP53 mutation, which are always selected. So prognostically, the detection of these mutations is very different from the detection of an ASXL1 mutation, at least on a population level. Now, one interesting finding is that in the pre-TKI therapy, blast phase was, of course, the chronic phase was shorter, but there were also more mutations acquired during the chronic phase and the non-TKI treatment. That is different now. So this is here the number of mutations, different mutations of mutated genes. And you see that this goes up steeply with the time to blast phase transformation. And now in the TKI era, this curve is almost flat, indicating that some of these mutations represent routes that are successfully suppressed by TKIs. And they don't appear anymore at the time of transformation. The mutation type informs us, or does correlate to some extent with the immunophenotype of the blast phase. And that is shown in this very elegant paper from a Japanese group here. So this is the odds ratio, whether you are lymphoid or myeloid. And so, for instance, TP53 mutations or ASXL1 mutations are very myeloid, whereas IKCF1 mutations and CDKN2A, this is also known as P16 mutations, are much more associated with lymphoid blastic transformation. Some mutations have an impact on overall survival. I told you initially that the presence of an ASXL1 mutation in chronic phase is difficult to interpret and should not lead to a change in therapy. However, if you have it at the time of blastic transformation, then it starts to impact outcomes, and that's shown here. Similar for TP53 mutations that by and large confer a really dismal prognosis. So in other words, this mutation screening gives us important information. Now, I already mentioned that the TKI therapy alters the mutation spectrum, but beyond that, we can determine whether or not individual mutations contribute to risk or prognosis. And again, this is this very elegant paper here. This is relative, or this is hazard ratio, log to hazard ratio. So the bigger the ball, the bigger the risk. And then this is the associated p-value. And this is enrichment in lymphoid versus myeloid blast phase, and then prior TKI therapy and no prior TKI therapy. So if you look up here, So patients, the typical patient today will have had prior TKI therapy. And so if you have a CDKN2A mutation, you'll find it typically in lymphoid blastic transformation. But the prognostic contribution of this mutation is relatively small. And so you can go and basically combine all this information into prognostic scoring systems to determine which ones contribute most to the subsequent outcomes. So let's end with a few cases. So case number one, this is a previously healthy 20-year-old who goes to the emergency room because he has night sweats and weight loss and left flank pain. He's really healthy, he's continued to play soccer, and then physical exam shows a big spleen. Standard labs are highly abnormal, white count of almost 400, low hemoglobin, high platelets. In the differential, there are quite a few blasts and promyelocytes. LDH is also high. So he's admitted with suspected CML. And so which tests are indicated? So the choice here is bone marrow karyotyping, bone marrow FISH for BCR-ABL1, BCR-ABL mutation screening, and myeloid mutation screening. So the answer here is bone marrow karyotyping. I think bone marrow FISH for BCR-ABL is not indicated because marrow karyotyping will give us the same information. BCR-ABL mutation screening, it's diagnostic, so we don't know what to do with the information, and it's low yield. And at this point, given that this is still chronic phase, despite the increased blast count, I would argue that myeloid mutation screening is not indicated at this point. So the patient has started anhydria and IV fluids. Bone marrow morphology is consistent with chronic phase CML, 10% myeloblast by flow. Karyotype is typical, all Philadelphia chromosome positive, but no additional abnormalities. And so he's chronic phase, but high so-called risk. Started on dasatinib, tolerates it well, comes back at 3 months, and BCR-ABL1 is 44% international scale. So clearly not a good response. Which of the following is not appropriate? Thorough evaluation for compliance, follow-up in 3 months, including repeat qPCR, bone marrow biopsy and karyotyping, mutation screen, myeloid malignancy screen. I would argue you cannot send this person home. You really have to look what's going on here. And so really everything else but number 2 is appropriate. So what happens next? Bone marrow biopsy shows persistent myeloid hyperplasia with 3% myeloblasts. Karyotype is 15% just pH, and then another 15 metaphases with just pH, and another 5 metaphases now carry an inversion 3 in addition to the Philadelphia chromosome. BCR-ABL mutation screening shows a T59 mutation and with a variant allele frequency of 50%. Myeloid mutation screening shows a TET2 mutation with a variant allele frequency of 15%. And a provisional 10 out of 10 matched donor is identified by HLA typing. So which of the following is correct? Inversion 3 is not a major route abnormality and as such shouldn't be considered to be relevant. 2, TET2 mutations are associated with a high risk of transformation to blast phase. 3, ponatinib 45 mg daily is the treatment of choice. And 4, BMT is not a consideration at this point. So I would think correct is only that the patient is a great candidate for ponatinib. Inversion 3 is not major route, but is associated with a high risk of blastic transformation. TET2 mutations are not associated with high risk of transformation to blast phase. And it's the significance of these 15% here is really unclear. BMT is not a consideration at this point. I think that's not correct. I think this is really a patient who should now be seen by the transplant team and considered for a stem cell transplant especially since he's only 20 years old. So what happens is that the patient is switched to ponatinib, and again, after 3 months, he's reevaluated. Now CBC is normal, but the tip of the spleen is still palpable. BCR-ABL is 15% international scale. Bone marrow morphology is unchanged. Karyotype is now exclusively either BCR-ABL positive with inversion 3 or normal male 46XY. Which of the following is appropriate? Continue 45 milligrams ponatinib daily and reassess in 3 months. Switch to omotaxin. Proceed to allogeneic stem cell transplant, or no definitive decision is possible without repeating the myeloid mutation panel. I would argue that this is now a clear indication for an allogeneic transplant, because what has happened under ponatinib selective pressure is that what's been selected is this inversion 3 positive clone. And there's a good chance that the patient actually has acquired what we would refer to as BCR-ABL independent resistance. So this clone will not go away with the BCR-ABL TKI. Let's go to the next case. An asymptomatic 22-year-old woman is found to have leukocytosis on a routine blood count during a health fair. Primary care provider sends her to a hematologist for workup. Post-medical is remarkable for substance abuse. Standard labs reveal a white count of 50, a left-shifted differential with a couple of blasts, but not many, and the CMP is normal. BCR-ABL with diagnostic workup is limited to BCR-ABL qPCR on peripheral blood because she refuses everything else, and that comes back at 45% international scale. Patient refuses additional testing, as I already said. What are acceptable treatment options? Well, I would think all of these options are acceptable. We don't have complete information, but this really looks like low risk chronic phase CML. So technically, to be really sure, we would have marrow karyotyping as well as a bone marrow biopsy and aspirate. But suffice it to say that I think all these are probably okay choices. Bosutinib and ponatinib are not indicated. Bosutinib is not indicated because the dose here is given as 500 milligrams daily. The starting dose for a newly diagnosed chronic phase patient would be 400 milligrams. So what's next? The patient is started on 400 milligrams imatinib daily and achieves a complete hematologic response very fast. BCR-ABL qPCR at 3 months is 5%, consistent with early molecular response. She complains about fatigue and total body ache. She's counseled about the benign and partially transient nature of these AEs, adverse events, and asked to return to clinic in 3 months. Now, the problem is the patient is now a no-show for her next appointment and then is subsequently lost for follow-up, which actually doesn't happen all that infrequently in younger patients. 3 years later, she presents to an ER with left abdominal pain, weight loss, diffuse bone pain. The spleen is now enlarged, and the white count is 250 with 31% blasts and quite a few promyelocytes. Blood chemistry is remarkable, high LDH, creatinine of 3.9, and uric acid of 14.3. So which diagnostic test is not critical in this situation? Bone marrow biopsy and aspirate, bone marrow karyotyping, BCR-ABL mutation screen, myeloid mutation screen, abdominal ultrasound. I would argue that you don't need an abdominal ultrasound because you already know that the spleen is big. So this is really not giving you any additional information. Everything else is important. You want to know, of course, whether this is blast phase also in the marrow. And you want to know by flow cytometry whether it's lymphoid or myeloid. You want to know the karyotype, and you want to know whether there's a mutation, a BCR-ABL kinase mutation, because she's previously been exposed to imatinib. And you also want to do a myeloid mutation screen to see whether there are additional somatic mutations. Now the test results are as follows. There are 50% myeloblasts by flow. Cytogenetics is all Philadelphia chromosome positive, but no additional abnormalities. BCR-ABL mutation screen shows no mutation, but the myeloid mutation panel shows tier 1 RUNX1 mutation at 24% VAF. HLI taping is also done and reveals a 12 out of 12 matched system. Now, which is correct of the following? Nilotinib is the most appropriate TKI to use. The RUNX1 mutation is probably present in about 25% of cells. The RUNX1 mutation is likely responsible for the transformation to blast phase, and the patient should be sent for an allotransplant immediately. So I would think the RUNX1 mutation is likely responsible for the transformation to blast phase is the only correct answer here. Nilotinib is certainly not appropriate. Actually, it doesn't even have an indication for blast phase CML. So I would argue probably the best option here is ponatinib as the most potent, currently approved BCR-ABL TKI. RUNX1 mutation is probably present 25%. Now this is unlikely because a VAF of 24% would suggest that about 25% of all alleles are BCR-ABL positive. And with that in mind, even if there were 50% of cells mutated, you would pick up only 24% RUNX1 mutated alleles. So this is probably not correct. The only way this could be correct is if there was a duplication of, or I should say, uniparental disomy of the RUNX1 carrying mutation. So a quarter of the cells would have a biallelic mutation of RUNX1, but this is unlikely because there are 50% myeloblasts. So the most likely scenario is actually that this RUNX1 mutant clone happened in the same cells that are now transformed to myeloblasts and have stopped their differentiation. So this is the most likely answer. Now, answer number 4, should the patient be sent for allotransplant immediately? The answer is absolutely not, because if you transplant into frank blast phase, the outcomes are by far inferior, and it's always advisable to do everything to establish a second chronic phase. So to summarize, you've already seen this slide here. Where are we and what might change? I won't cover this one again. I think what might change is that we will start to do mutation screening at the time of diagnosis if there is evidence for progression to accelerated phase or blast phase. And on TKI therapy, I predict this will become part of the normal diagnostic workup, because in some patients, even if they are technically still in chronic phase, you will pick up mutations in, say, RUNX1 or P53 that are associated with a high risk of transformation, and as such will provide important prognostic information. And with that, I stop, and I thank you very much for your attention.